This month, we're fortunate to hear from our Center for Equity in Health, Center for Health Equity in Surgery and Anesthesia, led by Professor Garuk Osgades, who's here. I'm sorry, my scrubs disappeared into the costume drawer long ago. But it's a real pleasure to have him here. There's going to be a cavalcade of stars from among his fellows and colleagues. So, Garuk, let me turn it over to you. Thank you very much. Thank you all for coming.
Good afternoon, everybody, and good morning, good evening. We have folks joining online as well. So I'm Garuk Osgades, one of the pediatric surgeons at Mission Bay. I'm also the director of our center, which is also called CHESA. I really wanted to thank IGHS for allowing us to present a little bit about our center and our work. We have some great speakers lined up for you today. I want to thank Stephanie for all your help organizing this session and the subsequent grand rounds that you'll hear during the year that represent a lot of the great work happening at UCSF and IGHS. I also wanted to point out a couple of key people in CHESA who are in the room. Patty Orozco, our deputy director, who's up here in the front. Zaina Tamalier, Zaina, where are you? Right here, our program coordinator, plays a critical role in our fellowship, who's up here in the front. I see Tyler in the back, who's one of our associate directors of research, who's an anesthesiologist. So we're a group and a center that spans a lot of the surgical disciplines and anesthesia and nursing. And so we're kind of a very interdisciplinary group. I have the privilege of introducing some of our speakers today. For those who are on Zoom, there's about, I think, 40 people in the room. There are mostly master students, and welcome to the master students. We're really glad to be able to have you as an audience today and others within the IGHS community. We have one of our speakers who's in person today, and that's Nathan Brand, who's one of our CHESA Fellows. He's a surgical resident, PGY 5-4 now, and who completed 3 clinical years and then spent last year as part of his 2 research years living and working in Dar es Salaam, Tanzania with MUHAS, a very close UCSF partner, and his co-mentor, Dr. Lia Akoko, is also on Zoom. So Nathan has a background in public health and has a true interest in surgical oncology and colorectal surgery and a lot of global health experience before joining the CHESA Fellowship. And he's going to talk about some of the work that he was doing in Tanzania. Dr. Akoko, who is on Zoom. Dr. Akoko, thank you very much for joining. I know it's very late, probably just after 10 p.m. your time. Can you hear us?
Yes, I can hear you, Garuk. Thank you so much.
Thank you so much for joining. So Dr. Akoko is an associate professor of surgery at MUHAS. He's been previous chair of the department. He is the only specialty trained surgical oncologist in Tanzania, and he's held a whole range of leadership roles locally in the Tanzanian Surgical Association and Society, the department, and also leading resident education for Tanzanian surgical residents, and really has driven so many projects to advance both surgical education and care locally. So we're very grateful to Dr. Akoko for making time, also for his mentorship of Nathan, but also all of the projects that he's really helped to spearhead in collaboration between UCSF and MUHAS in surgery. We also have 2 other colleagues from CHESA who are, I'm going to introduce everyone at the beginning and then we'll get going. But Dr. Lia Jacobson, who's on Zoom, is a pediatric assistant professor of surgery and pediatric otolaryngologist here at UCSF. And Dr. Jacobson also has an extensive background in global health. She has also worked in Tanzania, has active collaborations in Bugando, but also in Cambodia, a range of projects ranging from surgical education to service delivery, and has been a co-director of our fellowship, which you're going to hear about, the CHESA Fellowship. And then Dr. Sriranjani Padmanabhan, who is an associate director of ophthalmology, is also a co-director of our fellowship. She's a glaucoma specialist. She's based actually at Zuckerberg San Francisco General. She completed a global ophthalmology fellowship during her training and had been very active in global health, but also in domestic work around access to care here in the US for patients with ophthalmologic issues and challenges. So We're actually going to start with Dr. Padmanabhan and Dr. Jacobson, who are going to give a little bit of background about CHESA and about the fellowship. And then we're going to turn it over to Dr. Brand and Dr. Akoko to talk about one specific project, which was a fellow project that they worked on, which is actually just the tip of the iceberg of many things they worked on over the last year. So I'm going to hand it over now, if it's okay, to Dr. Jacobson and Dr. Padmanabhan. Thank you. Thank you both for joining. And we'll take questions at the end. Yeah.
Thank you so much, Daruk. Hope everyone can hear me. My name is Sriranjani Padmanabhan. As Daruk mentioned, I'm one of the ophthalmologists here at UCSF and at the Zuckerberg San Francisco General Hospital. I'm quite excited to be here with my colleagues to speak to you about our fellowship at our Center for Health Equity and in Surgery and Anesthesia. So we're pretty thrilled to be here. We will just start with a quick overview of what CHESA is and our flagship initiative, the CHESA Fellowship Program. Then we'll spotlight one of our fellow alumni, Dr. Nathan Brand, and his mentor, Dr. Lia Akoko, who's joining us from Tanzania. And they'll describe the project that they've developed during Nathan's fellowship year with support from CHESA. So I think most of us in this audience probably are quite aware that there are billions of people around the world who have no access to safe medical care, including 5 billion people or more who have no access to safe surgical anesthesia or analgesic care. And achieving the Sustainable Development Goals, universal health coverage that I think we all wish for our patients is simply not possible without access to surgical care. And surgical diseases accounts for about 30% of all morbidity and mortality worldwide and causes 4 times more annual deaths than HIV, tuberculosis, and malaria combined. 25% of maternal deaths could be prevented with increased access to emergency obstetric surgical coverage. And I guess the driving point here is that a huge proportion of the global burden of disease is surgically treatable and is, therefore worth a lot of our time, effort, and attention. In the United States, I believe we have nothing really to brag about. For example, Black men in their 20s have 20 times the firearm fatality rate compared to white individuals. Their maternal mortality rate is 3 to 4 times higher for Black women than white women. Black children have 3 times higher mortality for uncomplicated surgery, which I think is kind of a stunning statistic. Rural populations have lower cancer survival. And across the board, we have inequitable access to analgesia and satisfactory anesthesia care. And so we have a lot of work to do at home as well. In 2020, multiple initiatives and stakeholders, including the UCSF Anesthesia Division of Global Health Equity and the UCSF Center for Global Surgical Studies, came together to form CHESA. So some important things to notice about CHESA: we're one of the core centers at IGHS. We have over 500 members, including UCSF and non-UCSF colleagues from collaborating institutions. Our leadership is very diverse and inclusive, representing a range of specialties and both high-income country representatives on our faculty, as well as low and middle-income country faculty on our membership. The center is built on the foundations that Dr. DeVos had worked his entire career to establish. We are very grateful to work in this manner and contributions leading CHESA where it stands today. So he is still involved in our work as the chair of our advisory board. So CHESA is grounded in principles of social justice through equitable partnerships based on shared learning, innovation, knowledge creation, and translation. CHESA has 3 main areas of programmatic focus: research, education, and advocacy. The fellowship is our flagship educational initiative. And at CHESA, global health equity is the same thing as local health equity. We are committed to breaking down disparities in all settings, and many of our faculty and leadership have work focused on both domestic or international issues. And so we have intentionally excluded the word global from the name of our center, mainly because we don't want to mislead people into thinking that we're only focused on work outside of our borders. So our key objectives, breaking down what we do with our mission, we bring together silos and pool resources advocate for research and its subsequent implementation, expand partnerships in resource-denied communities, foster new models for academic leadership and collaboration, generate future leaders in perioperative health equity. And I think this latter objective is really where our fellowship program comes in. So I will turn it over to Dr. Jacobson now. I'll stop sharing, Leah.
Thanks. Actually, are you okay just continuing to share?
Yeah.
And I'll have to do next slide. Thank you.
No problem.
Well, it's an honor to be here, everybody. I'm Lia Jacobson. I'm a pediatric otolaryngologist at UCSF, and along with Sri, one of the co-directors of the fellowship. So I'll dive a little more into our program and what it encompasses. And as Dr. Padmanabhan mentioned, there are over 5 billion people globally, including 1.7 billion children who lack access to surgical care. So this represents a massive collective cause of health disparity worldwide. And a shortage of surgeons and anesthesiologists in resource-limited settings really compounds this inequity. So the CHESA Fellowship Program is designed to support and promote individuals committed to addressing this problem through a career focus on advancing health equity in the perioperative space. It's a one-year multidisciplinary program that fosters emerging leaders in global surgery and anesthesia through research, education, and advocacy, the pillars of CHESA. And the fellowship is designed to offer multiple interconnected programs that include UCSF mentorship on a year-long project and beyond that, longitudinally, career development support and leadership skills, structured curriculum and global health equity that focuses on global perioperative care, catalytic project support funding for fellows from low and middle income countries. And fellows join a highly diverse global community within the perioperative space that allows them to connect with each other through regular large meetings and then smaller community pods that are organized by specialty and or geography. We help provide peer community to reduce isolation and facilitate learning exchanges between our fellows worldwide. And the program is flexible, enabling fellows to participate part-time and remotely, hybrid and or in person at UCSF. And it's designed to be taken alongside training, employment, and clinical service. So this is all intended to help reduce barriers to participation. Next slide, please. So just to highlight our fellowship team, me and Sri, as well as our colleague Kathy Kiliawala, who is our third co-director and partner at Makerere University in Uganda, as well as Zaina Tomale, who I know is in the room. She's our program coordinator and has done just a massive amount of work to get this program off the ground and expanded in the last couple of years. And this is the power taken to support this fellowship really takes the village. The fellowship would not be possible without other UCSF CHESA faculty mentors and leadership, as well as access to resources and expertise across the university and outside of the university through our network of partners and affiliates in the global surgical and anesthesia space. Next slide. So our fellowship has grown to be one of the largest global surgery fellowships in the US, from 11 fellows in 2021 to 26 in 2023. We've had 55 fellows since 2021, representing 10 specialties in surgery and anesthesia across 13 countries. There have been 81 publications by fellows since 2022, and $148,000 in catalytic project funding from CHESA to support our fellows' work. Down below here, you'll see, or to the right, you'll see a distribution of where our fellows come from globally. The gender distribution, we've had 45% of our fellows have been female. In terms of career stage, many, 87% are early stage in their careers, but we've had some and have some currently who are mid or even late career. And 64% are from low and middle income countries, which is something that I think sets us apart from other programs. Next slide. So our current fellowship class, we have 26 fellows from 11 countries across North America, the Caribbean, Middle East, Eastern Europe, and Africa. They represent 8 surgical and anesthesia specialties, including anesthesia, general surgery, pediatric surgery, urology, ophthalmology, plastic surgery, otolaryngology, and orthopedic surgery. 76% are from LMICs and 42% are women. There's high demand for our fellows in this for our fellowship. In our last recruitment cycle, we received 4 times more applications than the previous year. Dr. Brandon and Dr. Akoko are going to highlight their project specifically from Dr. Brand's year as one of our fellows, but just to highlight some examples of the year-long project that a number of our fellows take on globally. We have bidirectional projects that have an example of which being the reuse of surgical instruments and PPE and bringing minimal waste solutions from LMIC to HIC settings. We have one of our fellows developed the first pediatric surgery service in Burundi, scaling of advanced trauma training across Uganda and regionally, improving surgical referral patterns in Ethiopia, pediatric airway safety initiatives in Tanzania, and a fellow looking at surgical outcomes in the unhoused in San Francisco. So a really diverse cohort of projects and fellows who all work sort of in tandem to support and promote one another's work. Next slide. And the last thing is just that we wanted to recognize and underscore that this CHESA Fellowship model is based on the experience of CHESA leadership's design and delivery of the GPAS Scholars Program, which supported surgical and anesthesia training in Uganda and achieved impressive results with this model. From 2008 to 2016, the UCSF program supported 34 surgical and anesthesia scholars in Uganda and 42 years of faculty time, and achieved 95% of in-country retention of trained surgeons and anesthetists over 10 years. 55% of the scholars were women, and many are now in senior leadership roles. These are some of our colleagues in Uganda who have gone through the GPAS Scholars Program. So our fellowship model is based on this experience and pulls in key components such as longitudinal mentorship, support of locally driven projects, many of which have now been scaled across the country of Uganda, and opportunities to build research and educational skills. And on that note, I will hand it off to Dr. Nathan Brand and his mentor, Lia Akoko, to describe the East Africa Lab initiative that they developed during Dr. Brand's fellowship year.
Perfect. So we'll start with Dr. Akoko. We'll start the presentation, but globally, this is a presentation on one of our projects, which was establishing a laparoscopic simulation lab at Muhimbili University of Health and Allied Sciences. So Akoko, you can start.
Thank you, Nathan. So we have had interest in developing minimal invasive surgery since many years. And we had many attempts, but were not very sustainable. The first one was when I was still a resident, when we were having this Canadian Network for International Surgery curriculum that initially was teaching only what we considered essential surgical skills. And then as residents, we raised the demand for more advanced skills. And so they came with the surgical skills for African residents, and in the component, there was laparoscopic surgery. So that was the first laparoscopic surgery training locally. And then when UCSF partnered with MUHAS to review our curriculum, Jessica Beard, who was a resident at UCSF, spent again 1 year with us, and we developed locally made laparoscopic trainer boxes to attempt to bring training and make boxes easily available to trainees. And again, that first up because the hostel did not have laparoscopic capacity. So early in the turn, I think it was 2014-15, Sam Finlayson visited MUHAS from Dartmouth through a SAGES effort. And this time now we had one laparoscopic established at the hostel, and he managed to train my colleague who is now the head of department, Dr. Mwanga, who has been our champion in laparoscopic surgery. And again, through regional collaborations by Johnson & Johnson Lab Skills Center in Nairobi, we have been able to send trainees to Nairobi, but COVID taught us that we needed to have in-house training, because now with the travel restrictions, it was not possible to continue traveling to Nairobi. And I understand the Nairobi Surgical Skills Center has since closed since 2020. Next. So while there is substantial interest in minimal invasive surgery in East Africa, only a few hospitals perform laparoscopic surgery to date. And we had a training on colorectal cancer where we invited all the 10 major hospitals in the country. And we realized that 68% of these hospitals have laparoscopic equipment within their hospitals, but only a handful of surgeons within those hospitals would perform laparoscopic surgery. And that resulted in only less than 5 laparoscopic cases done in these hospitals a week in 90% of the hospitals. Some hospitals, 10%, have the equipment but are not doing any procedure, reflecting a lack of training. Over 80% of the time, laparoscopic equipment would lie idle because the team would only be using it probably once or twice a week. So the number of laparoscopic cases in Tanzania could be much higher if these laparoscopic equipments were used in this 68% of the 10 hospitals. But we realize that a significant barrier is lack of training and expertise in laparoscopic surgery. Next. So increasing rates of laparoscopic surgery in East Africa has the potential to significantly improve surgical outcomes, and this has been well stated in literature. When you compare open surgery and laparoscopic surgery, you get fewer complications, shorter hospital stay, and improved quality of life among patients receiving laparoscopic compared to open surgery. Next. So even after discharge, open surgery is associated with longer recovery times and lost time. In one of the studies that we've been doing, we realized in our laparotomy study, which is the main study that Nathan was doing in Tanzania, only 11% of patients who underwent open abdominal surgery were able to return to work within 1 month after discharge, compared to 75% of patients in a study done in Mongolia, which is also a low and middle income country like Tanzania, when patients had laparoscopic surgery. So you can realize that we can bring back more patients to work if we would adopt laparoscopic surgery in Tanzania too. Next. So
go ahead.
That's you now, Nathan. Thank you.
Sure. So in order to address this gap, we launched a partnership between 3 institutions: Muhimbili University of Health and Allied Sciences in Tanzania, Universidad de Católica in Chile, which has been a leader in surgical education and surgical simulation, and has developed the LAP platform, which we'll discuss further, and that we adopted in Tanzania, and then UCSF, both through their surgical skills lab as well as through the Center for Health Equity in Surgery and Anesthesia. And the goal of this was to kind of combine everybody's expertise from 3 different areas of the world to try to establish a sustainable laparoscopic simulation lab that could be ongoing in Tanzania. So we created this lab, which really is based off of the LAP platform. And the LAP platform is built on 3 different pillars. The first is hardware, which is shown with the actual laparoscopic simulator, which you can see a picture of. It's kind of shaped like the shape of an abdomen that's distended with air, as one would be for laparoscopic surgery, with a high definition camera. And then that camera also serves as a relatively rudimentary computer that's able to record videos of trainees completing tasks that can then be uploaded onto the internet to receive digital feedback from the trainer. The second pillar is a curriculum. So the LAP has developed a curriculum that comes in 2 parts. It's the basic module and the advanced module. And this curriculum can really take people from being very novice laparoscopic surgeons to being able to conduct a totally laparoscopic hand-sewn side-to-side bowel anastomosis in under 25 minutes, which for non-surgeons is a very advanced laparoscopic skill, and one that I would say 75% of the surgeons at UCSF probably wouldn't feel comfortable doing, partly because they don't do it that way, but partly because of the skills required. And then the third pillar of the education is training a local trainer. So having the feedback, the expert feedback come from someone locally that's going to be able to be ongoing. So it's not something that would be started by me, but now that I'm back in clinical time, wouldn't necessarily be sustainable. So the way that a trainee kind of experiences the laparoscopic simulation lab is that you start, the curriculum is broken down into different tasks. The trainee will record themselves completing each task, and that will be uploaded onto a mobile application. The laparoscopic trainer or simulation trainer will then review the video and provide specific personalized feedback on how they can improve. This will be uploaded onto the account, and the trainee is able to review the feedback either through their own mobile phone, or if for whatever they don't, their phone doesn't load the application well, we have an iPad in the simulation lab that they can use to review their feedback. Then with the feedback, they continue to practice until they can complete the task within the amount of time that's required. Then they'll re-record, and it will be re-reviewed by the trainee, either by the trainer, either to be checked off, or to give more feedback if they need to continue to improve their time. So we started this in December 2022, and since that time, we've passed a number of milestones. So 40 surgeons have been registered in our basic laparoscopic curriculum, and those 40 surgeons have logged over 1,400 individual hours of laparoscopic training in the lab. We've hired a lab manager he's a non-physician that's both gone through the entire basic curriculum and then has gone through a teacher training course. So he provides 90% of the expert feedback for students that are taking the basic curriculum, with me just providing a little bit of time when I can. The lab has been fully integrated into the surgical residency, with all senior surgical residents being registered in the course and over 75% of them graduating before they graduate residency. We have provided 3,282 individual pieces of feedback for different trainees, and we received the Association for Surgical Education Platinum Award. So this isn't necessarily a scientific talk, but just to give a little bit of evidence that all this effort is truly worth it, here is some results of the 20 participants thus far that have graduated from our course. On the left-hand side is a busy table. The far left column are different exercises that are in the curriculum. Each one is a task. And the next column to the right is the amount of time, the median amount of time it's taken trainees to complete that task for their pre-assessment. And then you can see the precipitous drop in the amount of time it takes them to complete the task for the post-assessment. So for transfer of objects, for example, on average, or the median time was 334 seconds to complete the task. After graduating, that dropped down to 53 seconds. All of those were significantly different. The next table to the right is an assessment of outcomes of trainees performing a simple laparoscopic suture. And this is using the Objective Structured Assessment of Technical Skills rubric, which is a classic rubric for grading surgical performance. And as you can see in the post-assessment compared to the pre-assessment, the participants did significantly better and were graded significantly higher. So, like everything, this takes a village, and this has really been led locally by Dr. Akoko, who has been leading surgical education for longer than I've been interested in surgery, and has really created the foundation for which we're able to build this on. Myself as a CHESA Fellow when I was there, and now that I'm back as a general surgery resident. Dr. Julian Varas is an associate professor at Universidad de Católica in Chile, and helped develop the LAT program, and has been, him and his entire team has been incredibly supportive in figuring out how we can take something that's been developed in Chile and bring it to the East African context. And Dr. Adnan El Saidi, who's our Vice Chair of Education and Minimally Invasive Surgery at our department here. So with that, thank you for your time. Happy to answer any questions.
I'm going to work. He's going to be right there. Both yes, green.
Yes. Thank you, Krishna. Quick question. Thank you for sharing. It's very exciting, all this information. I've been working in the medical device investment industry for a couple of years. So I know some sort of like, issues you've been addressing from this, I mean, pretty much, from clinical experience. But here's my question. So from your, perspective, being in the physician, do you think, what would be the main drivers to, actually result in this, disparity of, for surgical care? Because it's very costly even for, residents here in the United States. I mean, you can, share any like from economic perspective or any kind of aspect. I just want to learn how you see this.
Akoko, did you hear the question? I think that it's addressing kind of barriers and costs and other barriers of laparoscopic surgery in Tanzania. I'm happy to answer, but I think you'll have a better answer.
Yeah, I think if you don't train, if people are not trained, then training becomes the biggest barrier, because then they don't show demand in spite of the benefits of laparoscopic surgery. Unfortunately, our governments have been so good. African governments are easy to put up infrastructure rather than training. Training might be a difficult aspect with our governments. Putting up infrastructure is easy. So if you demand laparoscopic, they will bring it. That's why in 10% of the hostels, all these were public hostels. So 10% of the hostels were not using it. It means they demanded, it was brought, and there was no training, or they were not supported. So I still think that training more would be meaningful. We trained 40, including training all our senior residents who are 22, and they are going to go to different hostels, and they are going to create that demand that they need laparoscopic facilities and equipment, and they are going to offer laparoscopic surgery.
Yeah. Thank you very much. It's just terrific. It's there are a couple of other pieces to this that I wanted to ask about. The first one is blood banking. If you're going to do major abdominal surgery and trauma surgery or not, you need a pretty reliable blood supply. Now, I would have guessed because of malaria, there would have been relatively mature blood banking, blood transfusion service. So that's one question. Another question, utterly unrelated, although it is sort of part of major surgery. So when you ran through all the disciplines, you didn't have obstetrics and gynecology on your list, and part of the surgical mortality. I'm assuming it's because structurally OBGYN residencies don't have 2 years of research fellowship built into the middle of them. But could you talk a little bit about whether that's something you plan to expand to, or what the kinds of rate limiting steps are? And I suppose this is for Lia as much as anybody.
Nathan and Dr. Akoko, did you want to talk about the blood banking first, and then Sri and I can address the question about OBGYN?
Sure. Akoko, why don't you, I hate being on a Zoom and telling you about what's going on in Tanzania. Why don't you take the blood banking question?
Nathan, you are more Tanzanian than UCSF, So I think blood is a real problem, and blood is a real problem because maternal mortality is quite high, and maternal mortality is attributed to with blood. So priority in all major hospitals is to save blood for maternal. So yes, anemia is also real because you see it in both elective and emergency surgical cases. Most of these cases would require blood. So if minimally invasive surgery would result into less blood loss, and that would be even more advantageous in our setups. But again, we would only be scaling it up slowly. We have a significant negative non-diagnostic laparotomies that would be saved because all this would require blood. They would be bleeding. Energy devices are also not that much available in many of the hospitals. The best you can have is a monopolar. So I don't know whether I'm answering that question. Nothing.
People are nodding.
Maybe if you could talk a little bit about plasma expanders and kind of the stuff the military has brought to the table, and whether that replaces the need.
For the most part, that's not typically used in at MUHAS. For the most part, there's elective surgery. You'll need to come with blood ahead of time and organize that, or else the surgery won't happen. For emergency surgery, it is a big problem as far as getting blood on short notice. But there hasn't been, I would say, a lot of use of kind of newer technology of plasma expanders that has been kind of in regular use, at least that I saw at the National Referral Hospital. And keep in mind, my only experience was at the National Referral Hospital clinically, which is at the top end of what's available in Tanzania. So that's not even to say that that's the same as what's available throughout the country.
Yeah.
Hi.
OBGYN question.
Dr. Jacobson.
Yeah. So regarding the question about incorporating OBGYN, I think it's probably just a matter of time. The fellowship has sort of evolved a lot in the last couple of years, as it is still quite new, and I think some of who our cohort is dependent on how the word got out. To some degree, that is still word of mouth, but I think we're trying to diversify how we market the fellowship. We also have faculty and partners within CHESA in the OBGYN space. And just sort of anecdotally, there are other fellowships. I'm in touch with a OBGYN fellowship program in Ethiopia who we happen to give a podcast together on the topic of surgical fellowship, global surgery and anesthesia fellowship programs. And so I think there are analogous programs out there, and there's likely a lot to learn from one another on how to expand and make these programs successful for our fellows globally. Sri, I don't know if you have anything else to add. Sorry.
Oh, nothing. I think you answered it well. I was just going to, I might just add that our fellowship is not necessarily limited by the structures of residency programs, as the fellowship is open to both residents as well as post-resident physicians and surgeons. So a large proportion of our fellows are actually early career surgeons and anesthesiologists. And so, even if there are certain constraints that might prevent an interested party from joining us as a resident, then they're still eligible to apply and become a fellow, receive project funding, and all of the training in their years as an attending.
One question right here and one online.
Hi, thank you for the presentation. So before I started my master's, I worked as an equipment specialist for a medical device company called Carl Stores. And at UC Davis, and part of my role was I did all the equipment for all the departments. Basic stuff like doing a high pot test on the lab equipment, doing case coverage for new demos, or if they had loaners. So I have a few questions related to that. One is, who maintains the equipment, like all the lab equipment, for example? I imagine there has to be a specialist on site who does it in the same way I was doing it for the Davis Hospital. And then the second is, if there's equipment that, for example, I can't repair, I would ship it out, and within 24 hours, there'd be a replacement for like a new uteroscope or a cystoscope that has a leak in it, for example. So how is that working at these more remote sites if equipment breaks down? And sorry, kind of related as well. at Carl Stores, we also put on like Saturday boot camp ENT training days where we would bring all our scopes and the residents would, use it for whatever cases may be going on. So are any of these medical device companies involved in this, or is this somehow separate?
For Akoko, you wanna take it, or you want me to?
I'll come after you.
Okay. So they have one tower at Muhabili that is a Carl Stores tower that has been maintained. They have biomedical engineering at MNH that received training and is able to maintain it, but you kind of bring up a huge huge vulnerability for these more complicated modalities, which are equipment breaking and equipment needing to be replaced, especially because oftentimes these institutions aren't receiving new equipment, they're receiving used equipment as a donation. So it's old to begin with, and then it's in a harsh operating environment. So with that being said, they have been able to continue to keep that single tower running since Sages helped get it there, I think in 2012. So they've been able to keep it running for about 10 years, which is very impressive. But it is a huge vulnerability with these more complex modalities. As far as kind of different companies being interested in supporting training, because I would say there's not much of a market in East Africa now. It's kind of the chicken and egg, because there's not a lot of people trained. There's not much of a market of things happening because there's not much of a market. There's not much attention that's paid to this region from the different companies. So as Dr. Akoko mentioned, Johnson & Johnson helped host the simulation lab in Nairobi, though it sounds like that wasn't necessarily a sustainable effort. We have been trying to reach out to these different companies because this seems like a very obvious way that they could support education and help build their business at the same time. Thus far, we haven't been successful, but that doesn't mean we won't keep trying.
Yeah, totally agree. Maybe to complement with the Gerald Rosen question on the question and answer chat, I think the best way to sustain it, I would still say, is to train more people. And unfortunately, Nathan knows we were using scissors that were better to be used as graspers. So we have always sustained the live surgeries with equipment from our simulation lab. So you might think it's what a simulation lab, but it will definitely reach the patient. It might be better than what we have with the patients. So sustaining them is a challenge, but if we develop a community of people who are willing to use it, especially if the private hospitals are going to take up laparoscopic procedures, we hope even leveraging with the companies now to bring down costs would be feasible. If you are bringing down an agent from Carl Stores to support only 3 hospitals, one, it's too expensive for them to maintain that distribution. So now if our scopes break down, they have to be transported to Dubai and at your own cost. And then it stays in Dubai for 3 months. Then they tell you, we can't repair it. You have to buy a new one. And that takes time. So on occasions, we have received the donation of the scopes, the light source, the camera. So if we have a good community of users in East Africa, not only in Tanzania, and that's why I think we are expanding our lab project to Uganda. And if Kenya would be interested, maybe we'll expand there in the future. If we build a community, a big community of users, then we will create a sustainability path to it.
I just want to highlight quickly too. I think one thing about having many disciplines of surgery that CHESA houses is the ability to highlight that across multiple disciplines, we use a lot of analogous equipment. So in ENT, Carl Storz has donated equipment, new equipment actually, to Bugando, and has supported rhinology and other training labs, cadaveric labs in East Africa. My partners overseas have mostly overseen that. And so I don't know all the details of the sustainability of it, but I think that in the spirit of trying to come up with solutions for sustainability, highlighting that there isn't just one silo or one area of surgery, which might seem like a small, area to invest or to do it. But if you expand it to the multidisciplines, then a lot of the equipment is, I think that just expands the idea that this is a valuable area to put in resources and build relationships and infrastructure for, so that equipment can be maintained.
So we have one more question, I think only one more, and then we are going to.
Thank you for your talk. I have a quick question. So surgery residents here and I think OBGYN residents have to pass fundamentals of laparoscopic surgery. Is there some sort of equivalency test that those residents also have to pass to demonstrate competency? And then my second question is, are there plans to expand this program to any other places in the surrounding region?
So the basic curriculum is built, teaches most of the same skills of the fundamentals of laparoscopic surgery. I would say that it's about twice as hard. So if you can pass this curriculum, you can pass FLS in your sleep. There's no set curriculum that's required or no set test that's required beyond the testing that's part of the curriculum for the lab program. But we have been able to register it both with Católica University and with the Medical Council in Tanzania so that they can get a certificate, and it will count kind of as passing, kind of as an equivalent to FLS. We've written a number of grants thus far. They've been unsuccessful, but we keep writing them to expand with the idea of hopefully expanding to other countries in the region. Specifically, if you look at kind of countries in East Africa that speak English, it's kind of an easy target. We just submitted a grant to expand to Uganda, which would be fantastic. The nice thing is because this program provides asynchronous and decentralized feedback, which essentially means the trainer provides the feedback in a different place and at a different time than when the trainee is actually doing the task. It allows you to leverage off of kind of one hub of expertise to support other regional areas. So in order to expand to Uganda, rather than them needing to rely on either trainees from the US or from Chile, they're going to be able to rely on local trainers from Tanzania that are already up to speed, and will be able to kind of train them and take over the burden of training the first Ugandan trainees until the lab manager in Uganda is fully certified to be able to start training on their own. And then as you create a bigger community, you're able to accommodate for, if someone is sick or if someone needs to go on holiday, and everything can continue to move. So this is a similar kind of modality and method for how they expanded throughout all of Latin America, kind of led from Católica University, but expanding to 6 or 7 different countries throughout Latin America.
Well, and I know we're almost at time, so maybe Patty, we can follow up separately on this, but I had some questions just about the fellowship more broadly. And two were, first is how are you funded? How's the fellowship funded? And the second is, how did you achieve such high, what I would think is high female representation in your fellows? Is that sort of an intent you set out from the beginning, and how does that play into your selection process? So other questions too about the modalities of the fellowship, but given the time, we can follow up offline. But it's really super exciting to hear about the fellowship and learn about what you guys are doing. And
yeah,
so congratulations.
Lia and Sri, do you want to take the question about female representation, or I can answer the funding question really quickly? As far as how we're funded right now, it's mainly seed funding through some of the departments that contribute to CHESA, and also some small philanthropic grants. But we are actively fundraising and have some potential interest from other donors to expand the model and get more support for our fellows, especially those from LMICs. So that's pretty much how we're funded right now. I think we mentioned how much fellows funding support we've given so far, and that's actually been restricted to just those from LMICs. We actually don't allow fellows from HICs to qualify for that support. This is recognizing the need for support to do the projects mainly for the fellows from LMICs. So, Lia and Sri, do you want to take the question about male representation in our cohort?
Yeah, I don't know that I have a very scientific answer about it, to be honest. I think that in our applicant pool, we've had a pretty balanced representation of both male and female surgeons globally. And I mean, I think our cohort has been largely sort of based in certain areas where some of, specifically East Africa, I'd say, for our LMIC fellows. And yeah, I don't know if Sri or anyone else has a real eye on how we sort of achieve balance and moving forward, how we intend to. I mean, I think this is something that we think about, but haven't almost, I don't want to say happenstance, but to some degree, I think this is a pretty fair representation of the people applying to this program.
Yeah,
I would agree with Lia. I think it is a little bit of happenstance, but we're hoping that we have more representation as time goes on.
Thank you very much. It's terrific.